Hello, and thank you for tuning into this presentation of our poster about tendon abnormalities seen on ultrasound and how they can predict some symptomatic tendinopathy later on in runners at a marathon and half marathon event. So the main reason why we started looking at this project was because Achilles and patellar tendinopathy, it is essentially a chronic overuse injury, and it just takes so long to get better. It's so costly in terms of what it allows you to do and what activities you are unable to do, and just the time commitment to really rehab it and try and get it better. And so one of the things we want to look at is, can we predict whether someone is possibly going to later on and develop some of these symptoms based on the ultrasound finding, even if they aren't having any symptoms at that moment? There are many things that kind of play into whether something looks abnormal on ultrasound from a tendon. So we can see here with these upper two images that this is the long view and this is the short view of a tendon, and in this case you see it's a very thin tendon. It looks pretty homogeneous. There's no irregularities in between it. And so when you have something that's a thick tendon like here, where this is much wider than this tendon is up here, that is a sign that maybe that's an unhappy tendon that's having some inflammation going on. When you have a kind of being hypoechogenetic, where you have these little areas in here that are just not the same sort of color or the echogenicity as you expect from the normal tendon up here, that's another sign that the tendon isn't doing as well. Other things you can get are calcifications, where you sometimes see, not so much in these images, but you see some shadowing below because of the calcium that's present there. You could see bone spurs coming off from attachment points. You can see the thick peritoneum, which is just the area around the tendon as well. Other things that you can also just notice, or we have this color Doppler on down here, is that you can just see increased vasculature within the tendon, and part of that is really trying with the body trying to deliver more blood flow to the tendon in hopes that it would help it heal itself, but usually it doesn't grow in a regular pattern, and thus it's not actually as helpful as you would like. So these are all key characteristics of ultrasounds that would signify a tendon as being abnormal. And if you see this in someone who's not having symptoms, again, as I said, our question is, can we say, based on the location of that tendon and what type it is, whether that person may actually go on to develop some symptoms? And so that's where this study came in. So we looked at asymptomatic runners at the Salt Lake City Marathon. We had 163 runners who were scanned with ultrasound at the pre-race expo. So this is before the actual day of the event, but when people came to pick up their race bib. 25 of those were eventually excluded just because they had started to notice symptoms at 2 weeks from after the race, and so we decided that was kind of right in that initial cohort, and thus they were excluded. In terms of the ultrasound images, they were captured by one person who scanned all 163 runners, and then two expert ultrasonographer physicians independently reviewed the images to determine whether it looked like an abnormal tendon or a normal tendon. And so an abnormal tendon would be if it had any of those other findings that we had talked about. Then, for everyone who has gone through, everyone had their Achilles and their patellas scanned on both sides, so that we really had a good view of all four of those tendons in that person. Then after the race, follow-up surveys were emailed to each of the participants at 1 month, 3 month, 6 month, and 12 months after the race. The final survey is still in the collection process. It was slightly delayed because of COVID. And we actually had really wonderful response from it. We made it a pretty simple survey. Basically, are you having symptoms right now? Are you not? And so with that, we see that initially we had 138 runners at a month. Only 5 didn't complete the survey, and the numbers continue to drop a little bit, but after 6 months, we still had almost 90% response rate, which is really great in terms of knowing that we didn't lose that many people to follow up. In terms of our kind of the demographics of the runners that we were looking at, on average, they had about 10 years of experience. They were running about 18 to 24 miles a week. About 2/3 of them ran the half marathon and 1/3 of them ran the marathon to see if that, in terms of who was running which race. And then as you can see in this table here, we talk about the presence or the prevalence of abnormalities in each of these runners. And so you see that they range from the left Achilles versus the right Achilles, the left patellar, the right patellar, and then just any Achilles. There was essentially almost 25% or a quarter of the people had abnormalities in at least one of their Achilles tendons. Almost 40% had abnormalities in at least one of their patellar tendons, and 50%, so half of the people that were scanned, had some sort of abnormality in at least one of the 4 tendons that we scanned. The other thing that we took a look at is, since we had 2 different reviewers who were looking at these images and determining whether they were normal or abnormal, we calculated the kappa to determine the inter-rater reliability. And for both of those, it was in the 0.6 to 0.8 range, which rated it as substantial inter-rater reliability, although certainly there would be room for improvement in that as well. Looking at our Kaplan-Meier plot, this is how the symptoms progressed in people who had normal tendons as well as abnormal tendons on ultrasound, and how they progressed to having symptoms later on. So this top dashed line here are the people who did not have any symptoms at the beginning, and then their ultrasound looked normal. And whereas this line here is the people who didn't have any symptoms during the race, but during the next 6 months and at these different time points at which we did our survey, started to develop symptoms. And with this one, in terms of at 6 months, there was actually a significant difference between the people who had normal tendons on Achilles tendons on ultrasound and the ones who had abnormal ultrasound findings for their Achilles tendon at the initial ultrasound. And so this was actually a significant difference with a p less than 0.001 and with a relative risk of 8.17 for developing Achilles tendinopathy symptoms at 6 months if you had an abnormal ultrasound. Taking this as a whole, abnormal ultrasound was also just an independent risk factor for a later Achilles injury, and this was calculated to be significant as well with a hazard ratio of 2.3 and a p-value of 0.027. Meanwhile, when we also took a look at the patellar tendon, these we didn't really find a significant difference between the normal ultrasounds and the abnormal appearance of tendons on ultrasound. So as you see here, they almost, they kind of meet again here, and there's really not a super wide difference between the two. And so this was actually just not a significant difference. So in terms of our kind of overall findings, we found that in terms of the patellar tendon, we couldn't really find we didn't find a significant difference in terms of if you have the abnormal ultrasound findings and when you're asymptomatic, are you more predisposed to or more likely to then go on and develop symptoms. Whereas with the Achilles tendon, we did find that we could predict the potential development or the increased likelihood of developing Achilles tendinopathy within 6 months if you have ultrasound abnormalities present, even if you are currently not having any symptoms. And so this is something where, you know, in terms of next steps and things that we want to go for, is trying to work on ways to develop and validate interventions for abnormal screens. So you are currently asymptomatic, but you have the suggestion based on the ultrasound that your tendons may be abnormal and may go on to develop this tendinopathy. What are some ways we can do to help prehab the Achilles tendon to kind of try and mitigate or prevent the person from later developing tendinopathy symptoms? So in terms of the next steps overall, we're going to complete the 12-month survey analysis and continue to see if we notice any difference with the Achilles tendon or even with the patellar tendon. And then also, you know, as we move forward and continue to refine this study to improve the ultrasound collection as well as try to automate the interpretation. And this kind of gets into some of the limitations of our study. We had substantial inter-rater reliability, but we didn't have perfect inter-rater or ideal inter-rater reliability, and that's something where it's certainly something we would like to move towards. With automation, for example, would it be a way to do that? Another thing to look at would be, for this study, we only used one ultrasonographer, which was great in terms of providing consistent technique, consistent evaluation, but also opens up for the possibility that there was parts of the tendon or something that were just in general overlooked and may have had symptoms or abnormal findings or may have shown something different. And so there could be some bias in terms of what images were captured and thus shown to the, as well as just what images were frozen and captured to show to the reviewers. And so that's something where we would also want to improve going forward. Other limitations of the study are just that it was a fairly homogeneous population. and that all of the injuries and the symptoms that people were noticing were self-reported. There was no physical exam by a medical professional who was done at any point during this study, and that could be something that could be potentially integrated going forward. That being said, in this case, since we were just looking for did they develop symptoms as opposed to did they develop tendinopathy, I think that was acceptable. So that's where we are right now, and we'll are looking forward to kind of expanding this study going forward. If you have any questions, then feel free to contact me at Sara Walker. It's sarah.walker@hse.utah.edu. Thank you very much to everyone who is involved in this project, and have a good day.